conclusion with a bifurcation. So this is our usual disclosures with myself, Dr. Kini and Samir Mehta, and then now today we welcome Dr. Kefal Dao. He is the Deputy Director of the Coronary Heart Disease Center in Fuai Hospital in China. As we know, Fuai is the largest number of interventions and bypasses done in the world. We are happy to have you. So let's continue our presentation with the case number 166, 59-year-old male presented with class 3 angina because of positive stress in multi-vessel disease. Patient had a EF between 45 to 52 in the past. Only risk factor is current smoker and high lipids. SAQ score was 56, means some moderate symptoms, and was taking amlodipine and torvastatin with aspirin. At that time, the cardiac cath was done, which revealed 2-vessel disease, which Anu will show now. We'll show go to the fluoro, please.
So EDP was 14 today. If you see, though this is LV gram with the JR catheter, antro apex.
Yeah.
It's a hypo and maybe even a little bit of dyskinesis there. Overall, EF was mentioned between 40-45%. This is we did the picture of the circumflex, previous PCI, and now RCA was your moderate disease, FFR negative last time was 0.92. So we have a dual injection. If you see the RCA injected first, and then you see the LAD, mid LAD, that is total, and a 95% large diagonal at that level. And there's a small diagonal that also D2 that comes later on. So this is where we are with this current angiogram today.
Yeah, see that segment looks short, non-calcific, but good collaterals. And the RCA, I thought, will be positive. We did the FFR of the right coronary, which was negative. Circumflex was positive. We put a stent, and patient is here for this bifurcation. So before we go on to individual point, maybe we can take the opinion.
Another thing that I want to mention is that one, you have a bridge in the LAD after the D2. Yes. LAD is diffuse after that. It's not like a large size vessel, so hopefully we'll plump up after we open it.
Absolutely, that was my thought also, that we may be surprised it's much bigger. And Samin, I was surprised. I thought the RCA looked severe. So let me introduce our Dr. Do and get his thoughts. Dr. Do, what would be your recommended approach in this case? Danny and Richard, are they able to, is Dr. Do able to hear us? Looks to be some communication issue there. Anu and Samin will get it sorted out, and in the meantime, please proceed.
Okay, let's go back to complete the presentation, but I'm hearing myself now. Go to the slides. Yeah, good. So that basically the case was, patient had the stent, EF was 52, syntax score 27, and OM was done. That time clopidogrel was added and metoprolol 50 milligram. XL started. Now plan for imaging and the contralateral angiography, which you saw it, stage complex PCI of the CTO LAD diagonal bifurcation using mini crush technique. So as you know clearly that for the CTO with the recent guidelines is a 2B indication unless you show ischemia, and this patient has a significant ischemia in the anterior wall on the stress MPI and is on double ischemic therapy. So it clearly is appropriate from a revascularization point of view. Okay, Anu, we are ready to go back to the floor now, please.
Yeah, we're going to start. Yeah. And today I have my assistant who is Udit, my fellow. He'll be helping me. So we are starting with Fielder Fine Cross. He has everything ready here.
Your first line of approach for CTOs.
Yeah. So we're just going there.
The same way Fielder Fine Cross, or you want Corsair, whichever way you want. It's a short segment, but it's tricky because it's a bridge collateral, and you have little that adverse factor. Although the bridge collateral is not counted in the JCTO score.
There's no bridge collateral.
There's no bridge?
It's more large side branch.
Okay. Yeah, large side branch.
Yeah.
Also.
I mean, a question has come for you that has there been any CTO you have done recently without bilateral?
No.
Good
So
morning,
very
guys.
good.
I can see
Yeah.
you now.
Oh, okay. Dr. Dow is online. So just let me answer this question and then we'll take your opinion how to do this. So question is, would you do this case without contralateral, I mean bilateral injection? Point is, we know that it kind of has ingredient, embedded
Engraved.
in our working algorithm that if it is a truly CTO, that will not even try. Even sometimes you have to do a two bilateral radials if patient does not have femoral. So because always you pay the price. So I think if it's a subacute, maybe, but if it is acute, then no.
Got it.
Yeah.
Doctor, though, in the
So
meantime, we
actually,
had,
I
yeah,
didn't see the angio, the baseline
Will
angio, but
okay.
we'll show
for
it to
me,
you.
is
We'll show it to you again.
Can we
Yeah.
show it? No, can we show him now? 1 second.
Okay,
it's
now
showing
before
the
that,
Okay.
baseline
I have to make.
angio.
Yeah.
Now, before that, I have to make a comment here. So
Yes.
if you see here, this is why always a side branch, your score goes up. So I have fielder wire. I'm trying to see if I can engage the proximal cap with the fielder wire. So let it play.
Yeah. This is it.
So, Doctor, though, here is
This one.
the
Yes.
previous angiograms, and the history
Yeah,
is that the
I can
patient
see.
had a circumflex stenting done, which looks excellent. The RCA FFR was negative.
And patient has a significant ischemia of the anterior wall with little bit of dysfunction, EF around 52%.
And even
Okay.
before I let Dr. Kinney proceed, what would be your approach? She has used here a support fine cross catheter and a fielder wire to start with. What would be your recommendations?
Okay,
You go
I
now.
think this is a
You continue.
CTO,
Well, I have to
not
make points. What's the
not
It's like
subtotal. There is no channel. I think bilateral injection is necessary. This is the first step. And my recommendation is first I will wire the diagonal and use iris to find the entry point. And after we check iris, maybe I can see the entry point. I can understand how stiff the proximal cap is, and I will choose a right wire. Usually in this type of case, I usually use double lumen microcatheter, and then I think maybe a UB3 or Gaia will be better. This is truly a truly CTO, I think.
Right.
Okay. Good. Anu, tell us what your plan.
okay. If you can let the fluorosave play.
Okay.
So we had a fielder fine cross, and this is which is typical because of the side branches that are there. I'm trying to engage into the proximal cap since it is a polymer jacketed wire, hydrophilic, not that easy to get, and one of the challenging issue
I think
here.
this is a
So
XT wire, XT.
No,
no,
regular.
this is a regular fielder.
Oh, filter.
So,
okay.
Gayatri.
Yeah. So
You
I
get
think
a
it's a
Gayatri.
time that we can change to any other wire. I would like to go with the Miracle 6. I will make a curve and try the Miracle 6. But all the points that have been mentioned by Dr. Wu are excellent. That if that's a different way of training yourself, that you want to use IVUS and understand where the proximal cap is. No matter where you think the proximal cap is, your fingers should move to get into the proximal cap. So let's
That doesn't work?
show how it will go. So we're taking the fielder wire out,
Apparently that camera doesn't work now.
and then
Yeah. But this camera is good.
can you show from
Yep,
that
right there.
how I made the curve?
So question is, why not Gaia 3? So that's the question versus Miracle
Okay,
6.
open the Gayatri so I can give the reasoning.
Yeah.
So Gayatri already comes with a pre-made curve, and if you see there, it's exactly what the teaching is, that you should have a small curve. So you see the difference with the curve. If you can see it now.
No, other way. A little bit pull. Yeah, good. Gaia is
very
a
nicely,
very
yeah.
small. Yeah.
Yeah. So
Nearly
this is the curve
90
I made,
degree
which I
angle.
wanted. Yes.
Yeah.
Yeah.
90 degree. Yeah. but little bigger. The guy is like 1 millimeter. You are about 3 millimeter on the tip.
Yes.
And the question is, what Dr. Dow felt that maybe he'll go with the Gaia 3 first, but you knowing,
he
but
said pilot.
yeah, pilot or Gaia 3? Is it Gaia 3 or pilot? Right? I mean, and clearly that here, you know, it's the same. I say that select your one of the wire, your best wire of your choice, and you go with that wire all the time. And this is where we are. You want to magnify it? That's okay.
Yeah.
Magnify. Yeah. So I clearly would have gone with the Gaia 3, and of course, Anu is always very comfortable with an expert with this Miracle 6 as a first line CTO wire.
Now die.
So what's the wire now?
It's a Miracle 6.
Anti-grade.
Okay.
It's a Miracle 6, yeah. So as I said, that I would have gone with the same with the Gaia 3, but this is the Miracle 6.
Okay.
Okay, and
I think
now
do you think we need a protected diagonal?
yeah, we will. I mean, we have 7 French. As soon as go through, question is putting a wire at this time. Unless it starts getting decreased flow, it is going to hinder our progress of the native CTO wire. So that's why. But we have the wire ready, both fielder as well as the run through for the diagonal.
I think, Doctor, those concern would also be because there is severe disease in the region of the diagonal too. But very good, Doctor, though. It's making it very nice having you make these comments. And I'm glad we've restored all the communication issues.
Now some die anti-grade. I want to see.
Anti-grade picture.
So another suggestion is in this type of case, I usually put a wire in the circ to make the whole system stable and make the backup stronger.
Yeah, very good point. So question is, would you do it even in the femoral or you do it in the radial or in both?
I usually use a bilateral radial approach.
Radial, yeah. So radial, I would definitely, I think femoral, we have the long sheath. You see that the sheath, which is 45 centimeter right there to the mid part of the aorta. So we, from that support, I would say clearly for the radial will be needed, but I think femoral, you don't need that extra. Many times you put this multiple wires, they always have a little tendency, even a good anticoagulation, making a clots and so forth. So unless necessary, in the radial, we'll do the same thing to have this extra support. But in the femoral, we'll just use the long sheath and then, of course, the appropriate guide. Yes. And keep telling us what you're doing here.
We seldom use long sheets, only for very tortuous femoral arteries.
Yes.
Okay.
No, we do routine. What we do is we routinely, every case, a long complex case, despite tortuosity, we use the long sheath. Because to us, that 6 French guide kinds of become 7 or 8 because of the long sheath and giving extra support.
So now you are using 6 French guiding catheter or 7?
No, this one is 7. This is 7 because we know the large diagonal we need to, once we cross, we are going to do a mini crush or technique, so a 2-stent technique basically, and that is why we went with the 7 French.
Confianza 9.
So it looks like that it's gone a little bit, but still at the last cap.
Well, when we look at the shape of distal cap, I think distal cap is also very steep. So
anti-grade, yeah. Okay, good.
Maybe a stronger wire, penetration wire would be better.
So actually,
we are changing it to Confianza 9. Yeah.
Okay, some progress, I think.
Yeah, but some progress.
Let's see, anti-grade or no, retrograde now.
Okay, very well. I think it's improvement.
Seems to be in the right place, but going into a septal there. But
yeah, let's do the contralateral.
Probably A or nay.
Good.
Okay.
In the true lumen.
Good.
Yep. Good. So this is the time now we are going to protect the diagonal, change this wire to our, usually what we do is immediately after going, advance the fine cross further, and then use the exchange length run through.
Same thing, I think if you see here, the way I'm moving this micro catheter, spin at the same time, if with my thumb and index finger,
Yes, see it very
I'm
nicely,
spinning,
Anu.
yeah, and then from the left, if you see here, again same, the left thumb and the index finger, I'm advancing it. Good. Now we'll change it to 35
fine
wire.
cross, right?
Yeah, this is a fine
fine cross,
cross.
right?
Yes.
But the Terramore guys told me we can't spin fine cross. But
so other one is a Corsair. Those are the two. Yeah.
Why you didn't choose a Corsair microcatheter for?
Yeah. No, anyone could be both. Just I would say that just to say the price wise point, the fine cross is around $400. Corsair is about 600.
Okay.
If we know, I mean, this one probably a case of Corsair, and I would have gone with a Corsair. So, but the majority of our cases, if CTO, I would say about 70% will be with the fine cross and 30% will be Corsair. That's one of the reasons. So it's just basically the cost issue, right? I know if there is, what else will be the difference? Why would you select one versus other?
The tip, this is, now they actually have come with a newer design, but the fine cross has a different tip compared to, if I can show the slides of this.
Right.
They are tapered.
Right.
You see that? They're tapered, which is both the Corsair as well as all the other micro catheters, and that is why I like it, because you are able to get into the proximal cap, exactly where you want to get into. I'll
Get the filter wire.
Yeah, I'll later on explain it how we want to do it.
Okay, so now we are going to protect the diagonal, very tight lesion, which we are going to take care with a 2.5 cutting balloon later. But what balloon you need for the LAD?
I think we can go with
2.520?
Yeah.
2.520 for the LAD.
Andrew, you think microcatheter slides?
Show the microcatheter slides.
To show the tip of fine cross, Corsair.
That would be highly instructional here.
And the turnpikes. We have the turnpike also.
Yeah, turnpike spiral is very good anti-grade microcatheter.
It's a very angulated diagonal.
No, actually, I think we went there a few times. But now the issue is it was 95% lesion. Now that we have the wire in the LAD, little bit of a bias. You see that? It's right there, but not.
Let's dilate the lesion, then we'll go.
Yeah, I guess we got to bite the bullet.
So you are using a run-through to wire diagonal?
This is a fielder.
Yeah, this fielder.
The same fielder that we use in the LAD, we are using it right now, yes.
And the run-through is in the LAD now. The main LAD run-through has been exchanged.
Okay.
It is so tight.
Yeah.
We may even need a
angulated catheter.
No, more than angulated catheters, we may need again the miracle. Okay, so I guess we leave this. We dilate the LAD and see how our diagonal behaves.
Okay.
Agree?
Yeah, leave that wire, but there.
So you want to dilate the LAD first, or?
No, ideally we would go with your step that we want to wire the diagonal. Now we are having issue with wire the diagonal, so we will dilate the LAD. Now if somebody says they want to take the angulated catheter, which is supercross or venture, and then wire the diag and then go for the LAD, that's okay also. But we want to dilate the LAD, thinking that when you change the LAD plaque, maybe the diagonal, wiring may get
But we have the risk after direct LED, the diagonal will disappear. We have the risk, right?
For the
The concern is
viewers,
that it may close.
Yes, yes,
Yeah.
we understand.
for
Yes.
the viewers in the meantime, here are the
Any questions coming up?
micro catheters. No, Anu?
No. I have to explain that
Yeah, we're
before
going to
he
wait
just
1
shows
minute.
it.
Yeah.
Okay, ready?
Good.
I think after the procedure, I'll
This
do
is a
that.
2.520.
Yes, go up. Yes. Down.
There's a lot of disease in the LAD distally
Yes,
also.
that's the
But
thing.
yeah.
That's why we had predefined that there's a bridge as well as diffuse disease. We have to be very clear the length of the stent. Go up here. Okay, down. Go ahead, get it sucked in. I'm going to pull back, okay? Good.
Yeah,
Go up
yeah.
here, go up here.
Go up here.
Okay, now we got it.
Yeah.
Yes. Down. Okay, let us see how diagonal is behaving. Okay,
Okay, let's take a
picture
picture.
of the antigrade.
Get a nitro ready, guys. Yeah,
Everything is unchanged there in the
yeah,
diagonal.
good.
Now the
Okay.
question is, did you want to dilate the LED further down?
Yeah, go with the same balloon, a little bit more.
Yeah.
Yeah.
But then we'll end up stenting.
No, but it's a lot of disease. I mean, you need 2 stents in the LAD anyway, and 1 in the diagonal. That was the plan. And that's what I told the patient
Okay,
also.
go.
Yeah, but just up to here. The rest we'll
Yeah.
leave it for Vejo. Yeah, this is the bridge,
Yes, down.
and it has been closed for a while. Once you give a little vasodilator, things will open up more. Yeah.
I think
Okay.
after we wear diagonal and dilated diagonal, and
Yeah.
then decide 1 stent or 2 stent.
Yeah, that is correct. Yes. And knowing that we still don't have a drug-coated balloon, some areas, moderate diffuse disease, we are starting the trial of the drug-coated balloon next month. Actually, maybe end of this month. But that only for the ISR. The 2 companies are starting the drug-eluting balloon, drug-coated balloon trials, both paclitaxel and sirolimus. We are part of the sirolimus, but they all are for the ISR right now. Once the ISRs are done, then they'll go to the native vessel as per FDA requirements.
Dr. Do, are you using a lot of drug-coated balloons?
Actually, not many. In my team, I think 15%. Only for instant stenosis and some.
Give me the fine
bifurcation.
cross, and I think I may need the miracle to go up here.
And for some CTO case, if it's not good enough vessel for stent implantation, I will use drug-coated balloon first, and recheck the angio 3 months later.
Okay.
You have the fine cross?
So I think that it looks like that it may require a little support and a stiffer wire.
Other wire we could try is what's called as a fighter.
Fighter, right?
Yes,
Fighter
fighter.
wire.
Made by Boston Scientific,
That's a good choice,
hydrophilic,
I think. Yes.
hydrophilic coating with the tip low. Hold on.
Oh,
Goes and narrows, tapers down to 0.008. You have the fighter? Let me see. No, you know what? Let me go with the fine cross, and then I'll try the miracle first, if not the fighter.
Okay.
in this scenario, we have many choice. I think Thin Black or XTR, XA also good choice.
Okay.
Now you want to try fighter? Okay, give fighter. Can you have the slide of the fighter wire?
No.
Anu, I've
Okay,
never,
show it.
Is this something you've been using recently? I've not.
No,
seen
no,
you
I've using it. Yeah, but
have not shown it, at least in our live cases.
not in a live case, but we have.
Yeah, well, wonderful.
If
I have
if anybody
fighter
can see
wire.
it, yes. tapered tip, hydrophilic coating.
Yeah.
We need to zoom, I think.
Yeah.
Okay.
On the blue, yes. Andrew, if you can quickly make something and show. Do it here only in the side. This is a good time to download the GuideWire app.
So it's a more of a concept of the Fielder XT, right?
Yeah, a tip is a little stiffer, that's it. That's polymer jacketed up to the tip. This is no polymer jacket and hydrophilic. Some dye.
Yeah,
Nice.
Okay.
right there.
Can you just fluoro save that?
It is. Anu, this was the fighter.
Yeah.
Fighter, yeah.
Excellent choice.
So tell us a little more characteristics. I'm sure audience will like to hear about
No,
this.
I want to show the slide.
But
Like
you
I
said there is no
already
slide of the
mentioned.
fighter wire yet, but you'll make it.
He'll just make it right
Okay.
now.
Okay, let's get a cutting balloon. So we have a 2.5 Wolverine.
You're cutting diagonal or LED?
Yeah, diagonal. So LED we did.
I think 2.5 cutting balloon, it's a little bit difficult to cross the
Make the turn.
region or
Yeah,
diagonal
right.
region. You can
So-
try it, but sometimes
Otherwise,
it
we get a
works.
2.5 12 high pressure.
So the other
go
thing
there,
was, two stent versus single stent. Once you have one is angulated, two 95% lesion, and the size of the diag is, I would say, close to between about 2.6 to 7.
Oh, yeah.
Yeah. So
No, I
large.
mean, this case,
Yes,
the
we will
question
need-
only
we
comes
should
that
go
if
with
you
the
do a
two
cutting
stent.
balloon and looks very good, do you want to keep it a stepwise?
No.
I would say we'll just go with lot of data from Europe that stepwise provisional. That's basically the whole concept what the EBC main trial was. And there is actually a review article of the left main bifurcation with the provisional stenting, and they talk about this stepwise. But I would say this kind of case is not a left main although, but it's a large vessel, just go with the two stent approach. And I think that's what we are teaching everyone. Two stent approach are good as long as you do it correctly.
Except the
Go up here.
body of this wire does not have
Flimsy.
a lot of,
Yeah.
very flimsy.
Then let's start cutting a little bit. So nose is there, but let's make a room. Otherwise, we have 2.5 balloon.
Go.
Yeah.
Go up,
Yeah, looks like a flimsy wire.
down.
Yeah. It will not, but we'll see.
It did, and then came back.
So would you please explain in what type of scenario you use cutting balloon?
Osteal lesions, ISRs, those are the two. Because if there's a calcific lesion, yeah, let's go up here. Yeah. The calcific lesion, we'll go with the rota.
Okay.
And then combining with IVL, although we did a trial called rota cut, we are trying to analyze whether cutting balloon with a rotational atherectomy with a small burr gives you better lumen stent area. A 60-patient trial has been completed, and we are analyzing the data, but otherwise we just go with the rota IVL, but
Okay, go up now.
cutting balloon usually for the osteal lesions like this. And ISR.
Good. Down.
Okay, so I need a high pressure. Get high pressure. It's not going to go.
Right. That's what
Yeah.
I thought too.
Yeah.
No, it would have if the wire was a better.
Oh, good. It went actually.
No,
Good.
it did. It goes but
Yeah.
comes back.
Yeah, I know. Just go slow.
Probably this
Down.
support of
Yeah.
Yeah,
Wire
support
support,
is
yeah.
bad.
Yeah.
We may have to chain the wire, I guess. No. Okay.
Unless the whole body of the balloon goes further in.
Yes.
Let's
Yeah,
push more.
go up.
No, let's push a little bit
I
more.
am advancing. It is not going further. Okay,
No.
down. Okay, let's
Comes
change.
out.
waist.
Okay. Good. Let's go with the balloon separate. Yeah. Yeah, 2.5 12 high pressure.
And after that, let me see if I go
Maybe-
side by side
maybe
fielder.
We need a longer balloon, huh?
For the osteal,
That's
yeah. So I mean, it's a short lesion, and so the just to open that, because rest of the vessel looks good. If we can just open it, even then we open with this non-compliant balloon, we may still end up using the our Wolverine again to cut the interelastic lamina, but it's not making the turn. So we go with this balloon first. And we carry only 6 millimeter. So it's a 6, 10, and 15. Wolverine comes, but we try to use the shorter one. So this is the 12.
Through
It's
easily.
a 2.5 12, yeah.
I think this approach will
Yeah.
be.
Cut it.
There you go. It's open
Okay,
nicely.
good.
I think let's just take care of this area first. And
Yeah.
if we need more, we put a stent later down.
Yeah, go up.
Go up here again.
Yeah. Good.
Good. Down.
Pull back and let's take a picture and see.
It's going to be a fairly large diagonal.
Yeah, good.
Ready?
Yeah, I think we have to still use that cutting balloon. Right? We have to cut more. Yeah, go take the balloon out. We still need that cutting balloon.
Okay, what's the stent size? I think we put a 27512 in the
Right. Diagonal and 3033.
Okay, 38? No?
38. No, 3038. Yeah.
I think 30 may be too big.
Or 2.75 38.
275 38. And
Both
then we decide.
2.75. 2.75 12 and 2.75 38. Xience.
Dr. Do, does that make you agree with that? The sizing?
I didn't hear it clearly. He said LAD 2 or diagonal 2.5.
2.75. I said good size. Yeah. So, and then maybe we'll, of course, the LED pump up, we will dilate a little more later. But right now, we're just doing a little more cutting balloon, little verapamil, rehabilitate the vessel.
Yeah, I think use cutting 2.5 cutting to cut the diagonal again and dilate all the way down to the LAD. And after iris check, I will decide the size and the length and
We have the iris ready, right, in the end? Yeah, good.
All very good suggestions, Dr. Do.
So maybe in this type of LAD CTO, there will be negative remodeling or
Give the stents.
or muscle bridging. So after check iris, we decide how to treat the LAD.
Go.
Right.
Go. If you want to make sure the ostium is really taken care, you see that few millimeters of the balloon is in the main vessel. Sorry, the diag ostium.
Yep.
So
Yes.
Very important point.
Yeah.
You have to be, you cannot be just at the ostium. You have to be half in the, at least, 1/3 to half in the main vessel. Then only you'll have a nice cut of the ostium. And then the point of the negative remodeling, and so is very important, particularly in the vessel which is
give me the
closed.
275 stent.
So let's go, and then we have the IVUS ready, but let's deploy the stents and then we'll optimize. Yeah, 212 first.
12 for the
Side branch.
And then now we can put the mini crush side by side, LED diagonal.
Yeah, right now we can remove the hands. There's nothing, the whole key part of the hand movements has been done. Now it's better to show our mini crush 3D, bifurcate 3D.
No, they will do it. Their hands will remain,
Okay.
but they will put it on the side. They don't need to show our face.
So no face, and let's show those.
People are more interested in the hand movements.
Okay, bifurcate 3D. Good.
White. Where's the other? Connect. Side branch is always white.
So this is a 27 by 12.
12, yes,
stents, right?
for the diagonal. Yep. Good.
And for
Okay,
LED,
38.
We still have a 2.75. Well, actually, we selected 2.75, saw the quiet disease, but knowing that we can always, we had to do a kissing balloon anyway, and we can use a bigger at that time, the balloon dilatation. See that so much diffusely diseased. I think it will be, it definitely will be 3.0, but we'll wait for post dilatation.
Okay.
So we'll have a 3.020 high pressure balloon.
Both the diagonal and the LED are looking good.
So far, so good. Yes.
So, I mean, most of the questions have been regarding the sizing, cutting
Yeah.
balloon, and all of them have been answered, and
Yeah. Beautiful.
a very good follow-up. And thank you, everybody, for your keeping the session interactive.
Okay, some die now.
The 3D app made it so much more relevant.
Yes. Beautiful. Yep.
Cine. And then who was the side branch? Good. Okay.
The beautiful part, Samin, is that
Diagonal had to go in.
the app and your actions are exactly superimposed perfectly.
Yeah.
Each step is exactly as if you were either watching the app or the live
Some die,
place.
some died. Yes.
Complete concordance.
Yeah. Okay, good. Go up.
Good.
Go up with the diag.
To our viewers, I'll also quickly introduce. You may have noticed that there is a new name of the company, BroadMed AV.
Go up
This
again.
is just the same Medin box with the complete ownership to
Down.
Danny Trottier. Danny, congratulations to
All
you
right.
and a company with the multitude of innovations now aggressively and beautifully moving into remote controlling, cloud switching, many more developments to follow.
You see the wire has been removed now,
I
and
removed the wire,
and then
yes.
we are ready to go up, right?
Yes.
Don't move.
Yeah, yeah. Go up, go up.
Go up.
Good.
So Danny, yeah, to become independent, we
Done.
congratulate Danny.
Go up
And
again.
Danny actually have a big task which will end in the, will show, present little bit data of the end of this today's presentation.
Okay. Down.
That he will be basically taking care of another big, I would say, revolution in interventional cardiology.
Absolutely. A
Good
vital
discussion.
day today for that. And
Yeah,
This is a sticky wire.
yeah.
Okay,
Many
that's
times
fine.
wire get stuck, so came
No,
back.
no, this
so
is
that's
a,
okay.
300 run through.
Yeah, yeah. Let's take a
Always does
picture
it.
anyway.
Okay, take a picture.
Yeah.
but the stent in the LED expanded very well.
Yeah,
Very
very
good.
good. It need little more, 3.020. Yeah, no, LED still have little dent. We'll do it, but anyway, now we'll
Run through. you
rewire
have
both.
360 we
Yeah,
have
yeah,
run
short
through.
run
we
through.
have-
And let's do the fielder wire first. Get back. Now we can go with the fielder first.
Yeah, first, let's wire the.
Right? Where's the fielder, guys? No. Yeah, let's do the fielder. And look at the how LED started pumping up.
No, you want to give more vasodilators?
Yeah, I did.
distally?
Just now, I did.
Clearly.
No, but we'll go down from this because it's open. Let's do the fielder first.
You're not going to get wildly ambitious about that second diagonal, no?
Yeah.
No,
No.
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 Good.
Yeah. So that's okay. As long as patent and it remains, that is what our goal is there. So we now going to do both wiring first before go on further.
Ay, ay, ay.
Back end.
Okay. Maybe it was something stuck there.
Yeah.
Go to the LED
You're going to run
diagonal.
through first,
And
okay.
then give us the.
That fielder. There was a fielder here. No. Went out somewhere. Get a new one. Yeah.
So that's the LED.
Yep. And this is the fielder. But I think the artery getting its gradual shape. Look at this. Yeah, and clearly that it's a 3.0, but that's okay. So remember then there is a bulge in the mid segment. So I think that area which is narrow, let's do a kissing balloon and then we are ready with the IVUS.
So, Samin, a question
Yeah.
has come. Are you planning to do something more to the mid to distal segment?
Nope. I would say leave those kind of things to the flow mediated vasodilatation. After these kind of cases, we know, after come back now, if there still remain, you see one focal area, then you can just do a little balloon. And those kind of the cases which I think in the future will go a little balloon and the drug coated balloon. But if we think there is a one area which is a little troublesome, that maybe just go with a balloon there. But otherwise, I would say just leave that because it's going to open up quite a bit. Yeah. And we're going to use the same 2.5 balloon which we had now,
Got it.
which we used earlier.
Which is the wire for the diagonal here?
Fielder.
Fielder.
Okay. So you switch from the fighter.
Yeah.
Just
So
because
yeah.
we need more support and
Yeah. Get our
Fighter is not a good wire to recross. No.
Yeah.
right.
Okay.
Good.
Well,
Okay,
it
give me
did-
the-
it did a
2.5.
lovely
I don't
job.
think it's going to cross.
No. That's what do we need now?
Give a 212.
212 first. Yeah. Question always comes that once you have done the mini crush,
320.
and I know that with the DK crush, people may go back with the same balloon, but I think it will be a tough, little difficult. So two ways you can try your 2.5 balloon or go with the 2.0 first and open the room and then do your kissing with the 2.5 which you already opened before.
Then get us a 275, right, for the diag?
No,
The
2.5 will be
2.5
okay. 2.5 you have it. Very high pressure, yeah. Which patient? I did room 3 and 6 already. Yeah, even 2 of giving a trouble. Yeah, this is a new compliant 2.0, but we can use a LED balloon to anchor.
But you have 20. That's the problem.
Yeah, that's okay. We have enough room.
No,
You have 38 room.
should never go.
Yeah. Yeah. Okay. The smaller ones, 1.25 balloons are on standby. We'll see. Yeah, just here. So we are trying to use, rather than going with a smaller balloon, just a balloon anchor technique. Let's see if they happen. Moderate pressure, good.
Okay, down.
Okay, down. 1.0. What do you want?
We may have to recross. Let me pull back here. Go up here.
Yeah, go up
20
here, yeah.
atmospheres. Go. Yeah. Get down.
So that I would say of the various, if anything negative about the mini crush is compared to DK crush. Of course, DK crush have multiple steps and so, and quite popular for many physicians. So two only is that side branch.
You go up
So
here.
we always can get with a mini crush side branch, but it's sometimes little stepwise compared to with a DK crush because we have opened the ostium. It's a little easy to go in.
Have you ever thought the stent, the type of the stent and the cells matter?
Yeah, that's another point.
Yes.
That various stents, some are a little easy to go, and we always try to recross first and see.
So can I ask a
Yeah.
question?
Yes,
When
yeah,
you
sure.
write the diagonal,
Yeah.
which from the distal strut or proximal,
Right.
which part
Yeah.
is better?
Well, I mean, we try to go to the distal.
No. I mean,
Yeah.
if we say optimal strut,
Yeah.
there's no way you will know which strut you're going unless you do multiple imaging.
But yes, if you have a choice, you want to go a little distal, cross at the level of the diagonal, pull back and try to go through the distal. But many times you are happy that you are able to recross it.
Mhm.
Okay, they want me to sign.
So I have a just
Samir,
Okay.
Samir, how many mini
I
crush have you
sign it.
seen me doing?
Oh, dozens and dozens.
Good. Have you ever seen me struggle
There I
like
go.
this?
Never.
Do you know what's the reason?
Well, multiple reasons. I think dexterity is one of them. Just going stepwise, I think, is the real important one.
No, in this case.
In this particular case, I think, which is what Dr. Do had also mentioned initially, I think the very severe angulation of the the diagonal may be contributing to it, but I think the guide wire support may have been a question, and I've been a
No, no,
little
right now to recross and get the
go through
balloon
it.
across. Yeah.
Yeah.
A smaller balloon, I think, first.
Well,
Smaller balloon.
often
And
I
then
think that
Give me a
upsize.
new fielder.
there are several questions which have come up right now. Why not twin pass used to wire diagonal as suggested by guest speaker in the beginning? Could have
No, no, how
used
twin
pass on
pass?
LAD wire. Yeah.
No, how can twin pass help you? It's not. If you need something, would have been an angulated catheter.
So Anu, what is your reason? Why? What is your explanation? Why so much challenge in this particular
What's the
case?
strength that was used?
I have tell
They
me.
use what stand?
Xience. Every case we show you was a Promus.
Right. Okay. That indeed is. So you think it's got something to do with the orientation of the
Stent, yes, stent design and cells.
yeah, and the cells, yeah, axis of the side branch. That's a very important point. I had actually, when you asked so many questions, but it had not struck me that these had been done with the Promus. And have you had a chance to even look it in a more
Okay, now get me the 2012 again, or you
that
think we go with the... Get us a 10 balloon. Yeah. Or 1.2. Okay, open. So we're going to 10 now. We recrossed it again. So now, remember the discussion always, there's a lot of data. Data means not a lot of data. Always there's a lot of discussion. Most of it is from the European Bifurcation Club, which is all white paper, where they have, and there are case report studies of having done multiple OCTs to say which strut you need to recross. Not that there's any randomized study to say this is the way it has to happen. Even this is a trouble here. Now this could have been also. Now get us a 3 or 12 high pressure balloon. Let me go to the. I'm going to recross again.
I think you can leave the diagonal wire there and use another wire. Choose a different path to wiring a diagonal to make it sure from the different cell. This is different cell.
Yeah. Okay, good.
this is the 1O balloon.
Yeah, 10 balloon. Okay. Now get the 2O. Go 18, 12, 20. Okay, good. Down. Rupture. Get us that 3 or 12 high pressure balloon. I'm going to anchor again. I think it's a combination of the angle of the diag also.
Right.
This is for the LAD, right? You have a 1.5 12. Don't have a shorter 8 millimeter. 1 to 8, right? Oh no, then give me 1.2 Sprinter Legend. That's probably better.
So Anu, here is the observation, and I'm going to read it exactly as it has been sent to me. We use the Resolute Onyx. It's good for recrossing the wire and the
Go
balloon.
up. Okay. Okay, good. Down. Don't open it. Yeah. I mean, we have so many live cases with mini crush. Never struggle like this. But I think it's a good teaching. How would you do? Recrossing here.
Excellent.
So same thing, you rewire multiple times to change the cell, which we did. Now you want to do imaging, and to understand that, I guess you could go to that. But what I was trying to tell you is there's no randomized data to say you have to go proximal cell or distal cell. Absolutely no randomized data. This is just a white paper. Okay, now this is a 1.2.
More of an observation.
Observe,
and,
yeah, or theoretical, yeah.
Right.
And most of it is not
Conceptualized
in vitro, yeah.
conceptual.
Vitro data, in vitro data. Go up again, go 20. So we go 20, 20 to really open the cell.
And I think the question of the
Oh.
resolute onyx to go to the side branches crossing, yes, same thing like with the Promus, much easier. Sometimes we do have a little difficulty with the Xience, but onyx definitely, because of little open cell design, better to go to the side branches. But most of the time works out like this case. You go with a small balloon and then went in, right? A small balloon didn't give any difficulty first.
Now I had to recross.
Ah.
But now get a 2O balloon, let's see if it goes. But once I dilate it, second time it's not going. That could be the angle.
Okay.
Usually you have this trouble when it's calcified. No matter how well you have prepared the vessel, when you have a lot of calcium, we do have trouble in recrossing into the side branch.
Well, the intent initially for the cutting balloon was a good one, but
Yeah. And ostium looks quite good actually. You see that? I mean, ostium looks very nice. Nicely expanded, no pinch. Sometimes you think they'll beaking. No, look at this. Very nice ostium. Fully expansion.
even the second diagonal is a modest sized vessel.
Mm-hmm.
It all.
Okay,
You
now-
have to go negative here first, right?
no.
It's a used balloon.
No, it's not used. Go up to the LED.
Yeah.
No, good.
What size is this balloon?
Okay, down.
This is the one which we used before or new 2.0?
New. Go up here. There's something that is not making a turn here. Okay, down.
And I would say that maybe put another run through in the diagonal. Maybe a little buddy wire.
The diagonal balloon is a non-compliant balloon,
Go up.
or
No, it's compliant. It's a compliant balloon. Yeah, give this wire. I think we just put another wire, or maybe same. Remember the fielder versus run through has a different support. So I think let's go back with leave that wire and go with the run through wire in the side, deflate the LED.
Down.
Yeah. Let's recross with the run through now. Usually our teaching is go through the stent struts with the fielder, easy, but many times in tough cases it will not give, like in this case. And
Go up now.
while at the level you have done a nice even pot, that all the
Down.
struts have been nicely expanded of the LED at that level with a 3.0 balloon.
So what is happening? See, now the wire is okay, right? When
Yeah.
I'm trying to go, then the angle, the wire,
Yeah.
see there?
So I would say leave that wire and let's go with the run through wire, another one. Leave that wire. Good.
Right out.
Go with the run through and go your 2.0 balloon on that. Now only question is, does it go through the same stent strut or will go through the different? We expect hopefully it goes through the different.
No, it has to go through the same.
Yeah. Okay, so let's go leave that in the LED.
No,
You want to bring in the guide?
May
Yeah.
not.
But leave it in the guide. Yeah. And patient is on bivalodin, so right? Yeah. ACT is good. So now question was, anytime when we go with the CTO, with a stage intervention, we try not to use the stronger P2Y12 of Brilinta or Procedural in this particular case. That's why we gave clopidogrel, and plan was that after today, I'll put him on to Procedural. I'm a more Procedural fan compared to ticagrelor. A lot of people will use ticagrelor as an agent, but I always have believed in it. Both are
No,
good.
this is destroyed.
Yeah.
You don't understand. You have a winged balloon in the
Okay.
thing. It
All right.
destroys the wire.
Yeah, sure.
Get me a new run through.
Okay. Keep this balloon clean. We are going to need it again. Yeah. So you
From
truly
screen,
said
I
it was a
saw
truly, yeah, sorry.
I saw the guiding catheter is very special. Oh, what's the brand
Yeah,
of the
so
guiding
so
catheter?
these are our Boston Scientific Mark guides. Mark is a very soft tip, but it seems so stable. It will not move because of the long sheath. And we use a 6 French majority. If we are putting a 2 stents, then we'll go with a 7 French, like in this case, and won't move. So that's a good advantage, as we talked about it. And the biggest advantage is that,
Of course, are ready.
yeah. So many times when we don't get these cases, guides for back order, then you and all those guides are a little stiffer, but good support. But those are the one cause dissection. So we actually had 2 left main dissections in last 1 year. Both were done with the EBU guides. None.
Okay.
We have no in life. If you say in last 5 years, we may have total 2 ostial left main dissection. All were radial with the mark. But in last 1 year, we already have a 2 left main dissection with the EBU.
Okay, understood.
They were even with the femoral. So now we have different wire, and going to try the same 2O balloon once again, and not anchor yet, but let's go with this, and then we do the anchor. And otherwise, to make a space, we use a Corsair. So now
We
it's
are ready with the Corsair if this does not work now.
Yeah, if it doesn't work, then you go with the Corsair, but this one should go. Because clearly run through with a body, better body, will be helpful. But 1O balloon went.
Yeah, 1.0 and 1.2 we were created a little, but I think the angle could be a trouble here. Okay, hold on.
Good. No, it is angle, definitely.
Angle and a different stent design.
Yeah. You want to just open the stud with the Corsair first? I don't think anchoring will help it. Yeah.
Maybe we need a different.
Okay,
Good,
went
good,
in.
good, good.
No,
Okay.
went in now.
Good.
Yep. So same thing. That buddy wire or little stronger wire. Yeah. And then we'll go 2.2. You get
Go
ready
high,
or
high,
2.5?
high.
Yeah.
Down. Good.
We are not started using the
up here.
open balloon because of the cost. It's about $1,200.
You have
And
the high pressure balloon?
yeah, the key is because in America, it's a reimbursement. If you're using atherectomy, you're using IVL, you are reimbursed. But you put a $1,200 open balloon, there is no separate reimbursement for it.
Okay.
So we have not used it. We are used like they gave us 4 or 5 samples. We have used it. But to us, the lab which does 25% cases as atherectomy because of the selective referral, I don't think there is a need for open balloon, opium balloon. It
12,
is.
man.
We are 2.5 there, yeah. So
2.5.
to me, I think it's a good for centers which are afraid to do or reluctant for the atherectomy. But of those atherectomy,
a
otherwise,
20,
because there is a
3.5,
separate
20.
reimbursement in America for atherectomy and IVL. So I think once you have the IVL available and atherectomy, probably no need for this high pressure. But rare cases maybe. So you might like to keep
And
1 or 2.
3.0 you have, right?
Yeah, 3 or 20 we have, yeah. You may like to keep in your shelf maybe for 1 or 2 cases a month. So we do about 80 of the 330 PCIs per month. About 80 of them are atherectomy, which is about 25% of the volume. And of that, the 100% of that atherectomy volume is about 80% is the rotational atherectomy, 15 is the orbital, and about 4-5% is the laser.
I think
Okay,
the
this is a huge
problem
one. Just one
yes,
second.
sir.
I will take care of this 1 second. Good. Bring back in the guide. Let me decrease the profile of this balloon. Yeah. So use balloon. So we are going to go decrease the profile in the guide. So you kind of wrap up and then try. And this one, if you do this case, will go now. If you do a anchor, this one you do anchor.
No, this balloon is a problem. Used balloons, they just don't go.
Yeah.
And they
This is the
just
trio.
don't
Yeah.
wrap up well.
Yeah. Yeah.
This
This
new
is trio.
balloons that they have
trio?
created,
Yeah,
believe
good.
me, when you reuse and use it, I think they're made for one-time use now.
Particularly the non-compliant ones.
Yeah.
They just
Always
don't
the
go back.
problem with the rewrap. Yeah.
Rewrap, and not only that, sometimes they don't want to, but don't want you to reuse it. Sometimes those things are, done as, in India, some places that we can reuse. But let's go. This trio.
No trouble. Maybe I'm
trouble?
on the same wire. Don't connect.
Connect.
Things don't go.
Okay.
Can you get me a new balloon, please?
Okay. Yeah. Keep this one. Which balloon you want now?
Just get us a 258.
8.
8? Your 258 high pressure? Give it.
Good. Take this one out then. You went on the run through and still did not go. Huh. Okay, now we are going with the new balloon.
And 3 already? 12?
Yeah, 3 is ready.
Good.
Okay, let's see. This is the test for this NC Emerge 2.58.
No, it'll go now. This is a new balloon.
Yeah.
8 millimeter and a 2.5.
Yeah, we always want to put the challenge. So the balloon should feel proud that I'm going to go in now.
Aye. Okay, good. Did not come out.
Now you'll see the power of the body
Good.
wire.
Yeah. You can take other wire out now. You don't need it. Third wire. Good. Yeah, take that wire out. Good. Okay, guys. Get a trio balloon quickly. Yeah, here. This is the trio.
Okay, last step.
Last step and get the IVUS warm up the IVUS.
I think I want the...
And now the Kiski's turn. Has been waiting silently for last 60 minutes. Our IVUS expert. Now, many times, even with the 7 French, you do multiple, this balloon advance, the wire rewrap occurs very commonly. But in there, you do a little balloon dilatation, inflate the balloon in the guide, and it will go in. Good. Ready? Okay, go.
No, wait. Okay, go. Kiss now. Yeah, we've done multiple inflation.
Yep.
Where's
You go
the side
16,
branch?
16. This, yeah.
Down.
Good.
Ready for the IVUS?
2 millimeter proximal both. Good. Right?
Don't go too high. Don't rupture it. Yeah.
12.
Down. Okay, ready for the IVUS. Any other questions?
So far, good. So why you are getting the IVUS? Do I present my data little?
No, I have to show some other things. And
I see. Okay.
I'm not showing you some. Okay, start your data.
Okay. While getting the IVUS, let's go to the presentation, please. So we are getting the IVUS of both. No, you want to show the picture. You have done enough work. Little nitro. We need to show the one angiogram first. Haven't taken a picture. I'm sure audience is waiting to see.
Waiting, and I can confirm it's going to look just excellent. I think the All the hard work which went into the diagonal was all worth it.
Okay, ready? Oh,
Thrombus or perf?
yeah.
Huh?
Thrombus.
How much was the ACT? Actually, one of the
Mechanical.
speakers had asked what is the ACT.
Yeah. So we tested before 383. Yeah, same multiple. Let's just squeeze it. Yeah. And we can give this is the kind of case intraprocedural
squeeze.
thrombosis.
You did it.
Intraprocedural thrombosis, and let's just do a 3 balloon.
No, 3
right
to
now.
5.
Yeah, 3.5 maybe even. 3.5 12 high pressure and IV Cangrelor. This is the kind of case you use IV Cangrelor. You take the diagonal wire out. Less wire, better it is. Remember, I always say.
Now, what if thrombus squeezes into diag?
I see. Okay.
So
Okay.
can you explain why the thrombus occur?
No, because multiple balloons.
Yeah.
Multiple balloons, multiple time back forth.
Yeah.
This is what we always say. Whenever
Like
you're
right
doing
there.
these complex cases, the lower the steps, the better it is. So multiple time crossing, multiple devices.
Little squeeze and you
Yeah.
have nipride ready also here.
Cangrelor is an excellent choice here too.
Yeah. Yep. So this is the kind of case, intraprocedural thrombosis, enough data from champion trials, all have supported use.
Now the only thing is we make sure it does not get into the dag.
Yeah.
That's it.
Would
Okay,
you
go.
have considered an aspiration catheter here?
I was just thinking,
Negative,
should
yeah.
we do it down? We've never succeeded, believe me,
Yeah.
in the past. Yeah.
No,
They just push it down.
Yeah.
So do you check ACT
Here,
during
low
the
pressure.
procedure?
Yeah, we are doing
If
it
the-
now.
if
Get
the
a repeat
No,
the
normally we don't. Patient is on Angiomax.
Yeah, but we repeat again.
Oh, so
5
5
minutes.
minutes ago was 383.
383, yeah. So that is
Yeah.
not the issue.
Yeah.
No, but other thing we have seen also with Angiomax when you're doing multiple devices, you do
right.
see this.
Sure.
And it's very commonly seen, especially if you're using Godzilla guideliner and you're doing distal vessel, same, you're struggling for distal RCA. And then what you do is when you're coming out, sometimes you see it in the
Very good. Yeah.
proximal vessel, proximal RCA.
The floor
Those
is
things
okay.
are very common.
Yeah.
Oh,
See,
Already
exactly.
also.
Yeah.
Already
Yeah.
improved.
Yeah, good. It will require some work. Yeah. So what we are going to do is trying to do some work. You want to aspirate now?
Mm.
Huh?
Yeah. See, it went into the diag also. Yeah.
Okay.
Okay, let's aspirate and see and Cangrelor quickly. Maybe that will take away. But looks like it's organized.
Kangaroo going in. Okay. So while they are trying to take care of that, but at least things are better. You see the ECG, good hemodynamic, no EKG changes. Will make it better cosmetically now. And we go to our presentation. Yeah, Pronto LP. What do you need? Pronto. Yeah, let's get a Pronto. Okay. So this was I left it, and now we go back to our presentation. Continuation, which we do usually, Dr. Dow, we present some data on some publications and then one focus review of the month. So 3 trials I'm going to present of the ACC, BioVasc, Revive, BCIS II, and Target randomized trial. And then the real world revascularization of left main disease, because this is a common topic, and we have latest data from Canada of various revascularization strategies recently published. So basically, the BioVasc study was comparison in a patient with acute coronary syndrome. We know the complete revascularization is the goal. But complete revascularization, you do immediate at the time or you do it stage. But remember, many studies have been culprit versus complete revascularization and then complete whether you do same time or stage. So now question comes down to that do you want to do a complete immediate or stage? And this was the data that you do within 6 weeks with a primary outcome. And about more than half were non-STEMI and 40% were STEMI as shown here in this trial done in 4 countries. And overall complete revascularization was obtained in 96-97% of cases, which we expect. And then basically the main endpoint of the study are primary outcome of death, MI revascularization and ischemia driven revascularization. And you can see here that clearly superior stage complete revascularization event rate was 9.4 at 1 year compared to 7.6 at 1 year. So clearly, difference of 1.8% in favor of immediate complete revascularization. And MI, see there is almost 2.5 times difference, 1.9 versus 4.5. But you see the major benefit is in 30 days. So many of these patients where you did not do the plan for stage complete revascularization after doing the culprit, patient came back within 1 month of the event, and that really made the difference in these two. And this is basically put it together: lower MI, lower unplanned ischemia-driven revascularization. Otherwise, no difference in all-cause mortality. Actually, was 1.9, and then of course major bleeding was non-significant, but definitely trended towards. But event rate of 7.6 versus 9.4. Individuals, they say STEMI, non-STEMI didn't make any difference. The subgroup analysis also not different. So basically, the message was: patients presenting with ACS and multi-vessel disease, immediate complete revascularization was non-inferior to stage complete revascularization for the primary composite outcome, and was associated with a reduction in MI and unplanned ischemia-driven revascularization. So therefore, there could be a pressure on us now to do a complete revascularization at time 0. There was a slightly higher fluoro time, of course, and so, but contrast, and so contrast in nephropathy, which we usually worry about, was not different between two strategy. Then this is a very complex presentation, had not been published yet, from the revived BCIS II trial. Remember, this was the trial of the low ejection fraction viable myocardium, PCI versus medical therapy. We did discuss last year, which favored that both PCI and medical therapy was no difference. But there are data. There are data that viable myocardium, the patients who have the mortality, if you have viable myocardium, your medical therapy was 16% in the meta-analysis versus 3.2%. If the non-viable, it doesn't make a difference. So there is some data, and then of course from the stitch, we knew that patient with a viable and non-viable myocardium, that with viable myocardium, they live longer. So viable myocardium, of course, difference later, and although viable myocardium, there is no difference in improvement and no improvement. As you can see in LVEF, subsequent mortality did not change in the STITCH trial. So this concept was ongoing, which we had in our revived BCIS II trial, that which patient all had the viable myocardium on CMR, DSC, SPECT or PET, and then lesion had to be suitable for PCI. And then they went for PCI. We know the outcome shown on the right side, no difference. That's about 5-year mean follow-up of these patients. So what they wanted to do, that let's combine viability, functional recovery, and prognosis, and put a revascularization in the center. Because we know the revascularization with the STITCH trial, there was no difference in functional recovery. But there are some data to suggest that STITCH trial, CABBAGE, did better at 10 years. So therefore, the viability and non-viability is always still to a discussion. So this whole field is, in these patients of the revived 2, they wanted to put it together with a various hypothesis that viability characterizes and predicts event-free survival. Second was viability predicts left ventricular recovery. Third, viability predicts response to PCI versus OMT. And then the left ventricular recovery predicts event-free survival. And the lastly, fifth hypothesis was that viability characterized by continuous variable. So there were a lot of hypotheses in this field which they wanted to test from the BCIS data. So basically, one of them was important one. That is, patient is dysfunctional, dysfunctional viable or dysfunctional non-viable. Very important based on the DSE contractile reserve, less than 25 or more than 25. And they wanted to compare that with the normal viable myocardium versus dysfunctional viable myocardium, that how much is the LV is involved. So, and then also the scar. There is a totally no viability, and LV scar basically, as you can see there, wanted to see that what % burden of the LV scar is corresponding to subsequent outcome, scar burden. So they did all the testings, as you can see here, from the core lab on the various aspects of the viability and follow-up, and put these patients in together. So I'll try to take you through this complex presentation, which took me a little time to understand, and I'm just going to make an important point. One, dysfunctional myocardium. whether you are 15% or 80% does not make any difference in all-cause mortality and heart failure, hospitalization. Dysfunctional but viable doesn't mean anything. Second, if you are all viable myocardium but functional, there is a clearly that higher is the functional myocardium, lower is the mortality. So that's a very good point. So it means clearly mortality goes up when your lower percent of the LV myocardium, but if the more LV is viable, mortality is lower. So viable myocardium, we understand that. Everybody knows. But what we knew, the red dysfunctional viable myocardium does not have any effect on all-cause death and hospitalization. While we were taught all throughout that if you are dysfunctional but you are viable, you should do better, but did not. Second, but the scar type, very important. Larger the scar, higher is the death and hospitalization. So clearly, if you have more myocardial scar, you are associated with higher mortality. Third, that if you have abundance of the dysfunctional viable myocardium, whether it's 18% or 41% or more than 41%, does not make any difference in the PCI or cabbage, PCI or medical therapy. So this was, one, presence of dysfunctional viable myocardium did not make any difference. Your dysfunctional myocardium, whether you do PCI or medical therapy, there is no difference as shown in these graphs. So therefore, only thing which, if you're all viable, your LV will improve. Dysfunctional, no difference in LV improvement. Scar burden, your LV will go down, will not improve, as shown here. Second point, the viability, that all clearly, whether you are dysfunctional, all viable, scar burden did not change. And the lastly, that if you EF changed more than 4.7%, then there was a cumulative lower incidence of death and heart failure. So with that piece together, very nicely they put it for us to understand. First point, that is PCI does not improve prognosis or LV recovery in ischemic myocardium compared to medical therapy alone, regardless of the viability characteristics at baseline. So this actually refute our hypothesis number 1 and 2. Second, that scar burden adversely predicts prognosis and likelihood of early recovery in ischemic cardiomyopathy. And this is independent of baseline EF or extent of CAD. So this is hypothesis 2, made sense. And then 3 and 4 basically was that the patient's abundance of dysfunctional yet viable segment was not associated with prognosis or likelihood of early recovery. So I think we did learn a few things from this. And the last paper I want to talk about, the target randomized trial, that is the CT angio. You have a 30 to 90% lesion. And now question is, if you do FFR or you do your regular stress test to manage those patients, because there is nice algorithm now, AI algorithm, machine learning, FFR you can do at time 0, so you can avoid some patients to go for coronary angiogram in these 30 to 90% lesion. There are enough data they have presented, platform and machine, which is the machine learning based CT FFR versus computerized fluid dynamic based CT FFR. The authors have presented those data in the past, and they wanted to compare, knowing the guidelines, that if you are non-obstructive CAD and your CT FFR is, your CT is 40 to 90%, then either you do FFR or you do stress testing. So this is our guidelines. So clearly that if you have a 40 to 90% lesion on the CTA, you can do to the cath directly, or many people will do the stress testing before sending for the cath. But what if you do FFR? And if FFR abnormal, then only they go for the cath. So this basically was the trial design. Trial design basically was that how many percent of patients, this is again 1200 patients, that 420 underwent, that after the CT FFR, you decided that positive FFR had underwent angiography. In the standard group, you did your stress test, and then 483 underwent invasive angiography. Purpose, the trial primary hypothesis was that by doing the CT FFR, less number of patients will have a non-obstructive CAD and will not require PCI in your 90 days time period. So this is basically the group was characterized clearly. You see that in the standard group, more patient had a stress test, and of course in the CT FFR group, everybody had CT FFR. Now, the disease-wise, all those are very simple. This is the primary endpoint. Compared to the standard group, the proportion of patients undergoing invasive coronary angiography without obstructive CAD or with obstructive CAD who did not undergo intervention within 90 days was significantly reduced in the CT-FFR group versus the standard group. So 28, basically what we did by using FFR in that CT group, you decrease the chances that you'll have a non-obstructive normal coronary. That's what's basically shown. Now, this was mainly driven by a reduction in the proportion of patients found to have no obstructive CAD in the CT-FFR group compared to the standard group. Basically, that FFR will, your negative FFR, eliminate patient going for coronary angiography. Now, only this point is that if you look at the angiogram, the follow-up, even after those angiography at 12 months, there is no difference in the outcome. A little more patients actually have a PCI in the CT-FFR group, but overall, the difference in the outcome was not there. Quality of score, life score, SAQs were not different also, and they put it all together that it's a good technique, but if you want to decrease the to show basically like normal coronary. So that basically points down to. So patient in the stable CAD, 30 to 90% stenosis detected by CTA, on-site, machine learning based CT-FFR study is feasible, safe and effective. And this reduces the proportion of patients with stable CAD undergoing invasive angiography without obstructive disease or requiring intervention within 90 days. The on-site CT-FFR strategy increased revascularization overall without improving quality of life or reducing major adverse cardiovascular event. So basically the cost was slightly lower. So this is a plus-minus message, but overall basically FFR, even with the CT, now we are doing it in the cath lab without giving the dye or without a wire. There are a lot of programs going at present using the FFR in the lab. So last one is the left main data from Canada. What is the strategy we do? Clearly, the PCI numbers for the left main are going up compared to the cabbage, as you can see, annual increase. But more importantly, why? Because these patients are more complex. Patient with a comorbid condition, older, they are not going for cabbage, they are going for PCI. So more complex PCI in the left main population in Canada. And you see that your baseline score, all low ejection fraction, everything is higher in the PCI group versus cabbage, and it led to the two outcomes. One, early outcome, which they don't define really. It's like 30, 60 days. Overall, no difference, as you can see the propensity match on the right side. But more importantly, at follow-up, that these patients, cabbage did better compared to PCI. The survival was 64.8. With the cabbage group versus 46.4 with the PCI group. Similarly, higher Mackie in the PCI group compared to cabbage. So clearly on the long term, cabbage did better compared to PCI except the stroke. So basically that's what we learned. The late stroke definitely was higher with the cabbage group, and but otherwise favors cabbage in terms of death, MI, and revascularization. So clearly that this field continues to evolve of actual treatment for the left main disease, and this basically a nice editorial that the heart of the multidisciplinary teamwork that finally given the clear preference for one type of procedure over another. Treatment size likely also affect patient outcome at some location, which was not part of the your statistical adjustment. Like FAME trial showed that cabbage could be very safe in elective setting with 30-day mortality of less than 0.5%. So key is that you need to determine patient going to live 5-10 years, probably cabbage is better. Patient going to live 2 to 5 years, probably PCI is equally good. So this is basically we come down to our final messages that immediate versus stage complete revascularization ACS, 2 thumbs up. PCI versus OMT to improve LVEF even in viable myocardium, 2 thumbs down, no benefit. And within that sub-study, dysfunctional, even viable myocardium does not predict prognosis or LV recovery. It's again a bad thing, except the scar burden predicts adverse prognosis and LV recovery. Third point, machine learning based on-site CT-FFR reduced no or non-obstructive CAD and increased revascularization. The second point, a recent report from the Canada regarding short and long-term outcome after left main revascularization suggested lower mortality, MI and revascularization, but higher CVA after cabbage versus PCI at 7 years. So these two short-term mortality were equal, but more important, underscore the importance of heart team decision in recommending appropriate revascularization in left main disease patient, considering patient's comorbidities and expected survival. So 3 quick questions. Following statement is false regarding the relationship of dysfunctional viable myocardium and revived BCS trial. PCI does not improve LV recovery, even in dysfunctional. Presence of scar predict adverse prognosis. PCI predict prognosis and LV recovery in dysfunctional but viable myocardium. Dysfunctional myocardium is not associated with prognosis. Dysfunctional but viable myocardium is not associated with LV recovery. Clearly, the answer is C, is wrong. PCI does not predict prognosis and LV recovery in dysfunctional or even viable myocardium. This is different our concept, but that's what the data are. Second, BioVasc trial of immediate versus stage complete revascularization, which is false. Immediate revascularization associated with lower primary outcome. Immediate revasc is associated with lower MI. Immediate revasc is associated with lower ischemia-driven revascularization. Immediate revascularization had similar major bleeding incidents, and immediate revascularization associated with trend towards lower mortality. And the answer was not a different lower mortality. Actually, mortality was 1.4 versus 0.8. So slightly higher, but non-significant. So E is wrong statement. Last, following statement is false regarding the recent report about left main revascularization from Canada by PCI versus Cabbage. Cabbage had lower mortality at 7 years, lower MECI at 7 years, Cabbage had lower early MI, Cabbage had lower CVA at 7 years, and Cabbage had similar early death and CVA in propensity match patients. Answer clearly is, it did not have a lower CVA, but had the higher CVA. So that was false. So with that note, we complete our presentation. And here, Anu has done the work where we left. Anu, you want to take us there?
I mean, quite an intense space and so much useful information.
Yeah.
Okay, so if you can see the angiogram, I think this is where we left,
Yes,
right?
we did. Yeah.
So we then went with the pronto. We ballooned first. After we ballooned, you see that I think some of the thrombus went further down.
Yeah.
Right.
So we did pronto, and we know this is always happens. It probably sucked it down, embolized further. But what we also did is do a lot of suction. Actually, we got a lot of thrombus out. We did a lot of suction and also change the Y connector, because when many things or times what happens when the balloon, you're taking out the balloon, lot of thrombus comes and it sits in the guide and usually gets stuck in the Y connector. Yep. So always remove the whole system, in the sense remove the Y connector, because there was some thrombus inside there also. So that's what we did. And then we just did a PTCA. Once this is after the pronto, we had nothing there. You see there's a thrombus, tail of thrombus at the distal edge. We just did PTCA and we got the flow back. Then we did a prolonged PTCA, 2-3 minutes. Now you see the proximal, what is happening. So there's only one way you take care of this thrombus. When we first did PTCA, it embolized. So you do PTCA again, it's going to, we knew that it'll go into the diag. We predicted that, but right now, don't go behind the diag. Let's focus on the LAD. So only way we took care of that, we put a large stent and post-dilated there.
Okay.
You crushed it. Good. Yeah. And then? This is the last picture.
This is where we are. We gave vasodilators and
go
this
to
and that.
Portal, take a last picture and see.
No, did you want to do IVUS or avoid anymore?
No, I think now we avoid IVUS. Everything looks so good. There will be some thrombus at the ostial diagonal. You see it. Yeah. I think we leave it. We continue IV Cangrelor.
So we give IV Cangrelor. We give a lot of vasodilators, and this is where we are.
And 1 hour after, we'll give a F. Now we are going to change it to Procedural.
No. You want to, if it's a Cangrelor, you give.
No, after 4 hours of Cangrelor, then you have to wait half hour.
Why not Brillianta?
No, you want to give Brillianta? Okay, yeah, that I know. But you can, remember with the comparative binding, you can give half hour later after half to 1 hour, but that's fine. With this, okay. We can Brilliant, yeah.
And not even that, we gave 2000 heparin also. Right, Will?
No, patient was already on drug.
Okay, caudal. So no, we were waiting if you wanted IVUS. Otherwise, I would not do IVUS.
Yeah, right now, less instrumentation, little more medicines.
Yeah, we gave a lot.
Okay, let's take a picture.
Last picture.
Yeah.
Every PCI hardwire is a nidus for thrombus.
Yes, that's it. Look at it.
So beautiful final picture.
Yeah.
Excellent. Good. Very good.
Final comments from you, Dr. Do?
We wanted to show the
yes,
slides of the fighter wire.
It's a very educational case, and especially finally when the thrombus occurred, used a lot of techniques to treat the acute thrombus, and also a very tough case, a lot of teaching point. So I learned a lot from this case. Thank you.
No, I cannot.
Excellent.
They have
Thank
to
you
change
so
it.
much for your participation, for your valuable comments. I'd like to also acknowledge Dr. Karthik Subramaniam as well as Dr. Thomas Wilson, who have posted some questions which I think have been answered.
No, we have to show the
One fighter wire with the, because you know our
Who took it
success
out?
of that fighter wire,
Well,
we
the
wanted to show that. Yeah.
Amazing thing about the fighter wire is this was all constructed as the case was going on.
yeah.
Just in time management. That's how Dell computers used to work. Okay,
Yeah.
Anu, please tell us.
So if you see here, diameter 0.1, it tapers down to 0.009. Tip load 1.5. So that is why the 0.09 with the tip load of 1.5, the tapering actually helps you to get into this kind of side branches, where I have used it mostly for this kind of diagonals and also torches or where you're not able to get any other wire through. This wire actually helps there. So it has a polymer jacket, which is a clear jacket, and then a hydrophilic coating. But the tip load of 0.009 actually helps, little bit stiffer 1.5 tip load. Now, can you say we could have done it with the Fielder XT, Fielder FC, or other specialty wires? Yes, I think you could have, but the success rate for me with this wire has been great, and I think we showed it also in this diagonal. And if this wire is not available, what else you could have used? You needed angulated catheter, because there was a question, can you use twin pass? You have to remember, twin pass is a straight catheter. There are two, there is a distal tip, and then there is another tip for the side. But what you need is an angulated catheter to actually, so that you will be able to navigate into the diagonal with that angulated catheter, rather than by using just a twin pass. That's where it is. And the other question we had, if you can bring the camera, there's no camera?
No,
this camera doesn't work?
Yeah, no.
Ceiling camera. Oh, ceiling camera. Give me a pen quickly. The other question was about, can you show the slide of the microcatheters? No, the picture, big pictures. Do you have it? The tip. Okay, yeah. You have the fine cross. So if you see Corsair, tapered tip, Turnpike, tapered tip, but look at the fine cross. It is not tapered, it is straight, flat. And that is very helpful. And the biggest reason is, if you can now bring the ceiling camera here. So you have tapered tip, and you're getting into a CTO. Then you have your straight blunt tip, and you're getting into a CTO. So what happens is, you have a wire and you're trying to get into the proximal cap. You're not able to, so you remove it. So what happened with this tapered tip flop, which is floppy sometimes, get onto your, I would say, the wall, and when you're bringing your next wire, you end up subintimal. And this has happened very often with me. Compared to fine cross, where you have the blunt tip, it just sits there, and when you are able to change the wire, it will still be in the lumen rather than get into the subintimal space. So that's my explanation why I like a fine cross better than a turnpike.
I never saw this kind of illustration on this. Excellent. Sameen, a wonderful presentation. Anu, so many teaching cases, teaching points, tips and tricks to cross such a complex side branch, the management of thrombus. Dr. Do, thank you so much for your comments, to our viewers for keeping it truly interactive. And lastly, congratulations, Danny, on your new company and look forward to many years of collaboration. We'll conclude here and see you during our next visit on May 16. Samin, any final observations from you?
Good. No, we are done for this part, and now we go to the slide presentation for the new project, which you have been working for 2 years. I think it's okay to show now because the time has come. It starts tonight. Basically, the MedStream 360, 24/7 live. But the day-wise, right now it's a half the Tuesday, then start next day, but continue 24-hour live channel as shown by the various time frame, which Dr. Samir Mehta had done a tremendous job, and we as Sinai will be doing the cases from 4 to 6. Start with the coronary, myself and Anno, and then Prakash Krishnan. For 1 hour, we'll do a peripheral case with my son, actually, Raman Sharma and Vishal Kapoor. But just to say that finally the dream has come to light, to the fruition of 3+ years of relentless work of Samir Mehta, and I really congratulate him with a lot of hurdles, but to get to this, and of course in this whole, I would say, the process journey, Danny, now with the new company name and with the Med-Inbox earlier, has been a great partner. We wish everyone who is involved in MedStream 360 a good luck for the grand start this evening, 8 p.m. with a little discussion at 7:30.
Samin, thank you so much. It's been an incredible project to take it forward. Sitting next with me here is Kimberly, who's been our program director. Would like to thank her, to you and to Mount Sinai for making this happen, and of course invite everybody today to join us at 7:30 on the same CCC Live as well as the MedStream 360 website. The ways to connect are obvious and clear, and we'll see you this evening.
Fantastic. Good luck.